fibrillation, I hope I pronounced that correctly. The condition, better known as AFib, makes your heart beat abnormally, out of rhythm. 2.5 million Americans have AFib, including Barry Manilow, who is now speaking out on how it's affecting his life and his career. CBS News national correspondent Ben Tracy reports.
1, 2, 3, go! At an age when most people retire, Barry Manilow shows no signs of slowing down. He sold 80 million albums and performs hundreds of concerts a year to sold-out crowds. But 15 years ago, he suffered an episode that changed his life.
I was driving home, and I felt my heart skip a beat. Well, your heart skipping a beat doesn't sound like it's anything serious, so I didn't pay much attention to it. And then it went long, long. And it got crazier and crazier. It felt like there was a fish flopping around in my chest. It's a little I called my doctor and I said, what is it? He said, money. And he knew exactly what it was. It was atrial fibrillation. I think it did scare me half to death because anytime a doctor tells you that your heart, really, my heart, there's something wrong with my heart. But he said, not to worry about it. It's really good that you called us because that's what you got to do.
AFib occurs when the upper chambers of the heart beat faster than the lower chambers, causing an irregular racing heartbeat. Since his diagnosis, Manilow uses one of his biggest hits to tell him when his heart is beating to the right rhythm.
Your heart should feel like this. Here's the beat of your heart. At the Copacabana. That's a regular heartbeat. Atrial fibrillation is, and that's my version of rap. That's what it feels like. Your heart is crazy. You wouldn't believe what I did. I can't remember one time where I've been on the stage where I felt that, but I do remember one time that I was scheduled to do a show with the Boston Pops on July 4th, and I got up that morning and I felt it kick in. And so I went, at about 11 o'clock in the morning to this hospital, and they said, yes, Ms. Manilow, you're in AFib, you're out of rhythm, and we have to stop it, which means the paddles, clear, bang, and they have to stop it somehow. And I did the show that night, and nobody was the wiser. I take my medication and it calms down, and I go on my life. But when I can't stop it, then they have to cardiovert you, clear, bang. And I can't tell you how many I've had of that. Oh my God, how many people I have met that have this condition, but a lot of them don't do anything about it.
Manilow has been hired to help launch a campaign to raise awareness about AFib, and he works closely with his cardiologist to keep his heart healthy.
I didn't want people to think, oh my God, he's got heart, this and heart, I'm okay because I take care of myself. I said, don't worry about me. The reason I'm doing it is because I'm worried about you. I'm worried about all these people who have this and are not taking care of themselves. So yeah, I'll take the responsibility about talking about it. My pleasure. I hope I can help somebody with this.
Ben Tracy, CBS News, Los Angeles.
Thanks very much for coming. My name is Sunil Shroff. I'm a cardiac electrophysiologist over here at Silver Cross Hospital. I'm a specialist involved in the treatment of heart rhythm disorders. A very common heart rhythm disorder called atrial fibrillation is the topic of discussion for tonight. We'll start at a very basic level. A heart is basically a pump, and the job of the heart is to push blood to all the organs, tissues, and cells to deliver oxygen and remove waste products. The structure of the heart consists of 4 chambers, 2 atrial top chambers and 2 ventricles or bottom chambers. The heart is an electrical system that tells the heart when to activate or when to go. The electrical system starts in the sinus node, which is in the right atrium. Signals initiate there, and they travel to this connection between the top and the bottom of the heart called the atrioventricular node. There's a filter and a delay in that signal, and then the signals go to the bottom of the heart. They go through these fibers called Purkinje fibers. And then that tells the bottom of the heart to activate after the top activates, after a delay. Now the normal heart rate is between 60 and 100 beats per minute. Now, what they call an arrhythmia is a condition where you don't have a normal rhythm. And there are 2 types of there are two basic types of arrhythmias. There are bradyarrhythmias, or slow rhythm problems, where as a result the heart is going too slow, or what's called tachycardia, or a situation where the heart is going too fast. Conditions that can make the heart go too slow. There's a condition called sick-sinus syndrome, where the impulses don't fire fast enough coming from the top of the heart, and the heart goes slow. There's another condition called atrioventricular block, where there's a delay or blockage in this connection, in the connection between the top and the bottom of the heart, where the resulting heart rate can be slow. There's also a situation where the heart can go too fast. A very common cause of the heart going too fast is a condition called atrial fibrillation. And this is very disorganized, irregular activity in the top chamber of the heart, where the signals are moving around very, very quickly. And they're conducting to the bottom of the heart very, very quickly through the conduction. And what you get is a very fast heart rate because the signals are coming so fast from the top. And what you see is very disorganized electrical activity from the top of the heart. This is before, we're seeing this small signal here before this very large spike, which is the bottom of the heart contracting. You can see here when the top of the heart is contracting, it's very irregular and disorganized and very rapid. And then the bottom of the heart is very regular also, and very disorganized and very rapid. So, like we just mentioned, atrial fibrillation is caused by disorganized electrical impulses coming from the top chambers of the heart that can conduct very rapidly to the bottom of the heart. And the heart conducts very fast and irregularly. Now you can see here what it looks like. The top of the heart is going very fast and very regularly. In normal rhythm, it's a more coordinated contraction from the top to the bottom. You can see here exactly what this looks like when the heart is in atrial fibrillation. Atrial fibrillation is very common. This is the most common sustained arrhythmia we see in clinical practice. It can affect up to 1% of the population. The incidence of atrial fibrillation increases with age. By the time patients are in their 70s, 4% of the population can have atrial fibrillation. By the time the patients in their 80s, it's very common. About 10% of the population can have some sort of form of atrial fibrillation. Atrial fibrillation is going to be more common. There are more than 6 million people are affected today in the United States, and they estimate by 2035 more than 10 million people will have this condition. AFib is also very common after heart surgery. Between 20 and 40% of patients who have bypass surgery or valve operations will have atrial fibrillation afterwards. It may have to do with inflammation in the heart associated with surgery. And usually this tends to be self-limited and will go away after a few weeks. So it's not a permanent condition a lot of the time if it happens after an operation. Well, what problems does atrial fibrillation cause? Well, patients can have symptoms. Patients can have very mild symptoms with a feeling of palpitations or an irregular heart rate. Patients can have chest discomfort or chest pain or a sensation of tightness. They can feel their heart racing. They can have lightheadedness. They can have shortness of breath, which could be mild, and fatigue that could limit the ability to exercise. Patients can also cause very serious symptoms, and serious symptoms usually result in hospitalizations. In the U.S., more than 2.5 million hospitalizations every year. But more extreme shortness of breath with exertion, feeling like you're going to pass out, or almost feeling like you're going to pass out. This could be a reduction of blood flow to the brain. Also, there could be confusion due to this reduction of blood flow. There's also more extreme chest discomfort and more extreme fatigue. The other big problem that atrial fibrillation can cause is stroke, and this is very common. And what's happening is in the top chamber of the heart, there's very disorganized and ineffective contraction in the atrium. There's pooling of blood. There is very little movement of blood. And the blood can clot and form a blood clot. And that blood clot can travel to the brain and cause a stroke. And the most common place we see this is in the front of the upper chamber of the heart. What you can see here is an image called a transesophageal echocardiogram. This is a study where we have a patient swallow an ultrasound probe so we can get a good look at the top chamber of the heart. We're looking at the heart from the back of the heart. And this is the upper chamber called the left atrium. And then in front of the left atrium is this part of the chamber called the left atrial appendage. And that's where you normally see the clots. And we can see this when we do a transesophageal echocardiogram, somebody has a clot. And in this image here, you can see a blood clot, where this should just be an empty space. There's a blood clot there.
During atrial fibrillation, the atria quiver because of chaotic electrical signals in the heart, resulting in an abnormally fast or irregular heartbeat. Because of the abnormal heartbeat, blood may pool in the atria, which can result in the formation of a blood clot. If the blood clot passes into the general circulation, it may cause a stroke.
Now, there's a way we can predict an individual with atrial fibrillation's risk of stroke, and it's called a CHAD score. So everybody with atrial fibrillation should know what their CHAD score is, because this is a very accurate way to predict your yearly risk of stroke. And what CHAD stands for is, one factor is congestive heart failure. And what that means specifically is an ejection fraction which is less than or equal to 35%. That's the pumping function of the heart. So if the pumping function of the heart is severely reduced, that's a risk factor for stroke. It gives you 1 point. Another one is hypertension. Having high blood pressure, getting treatment for high blood pressure is another risk factor for stroke. Being old, we define old as being aged 75 years or older. That's a risk factor too for stroke. And then of course diabetes is a risk factor for stroke. People who have already had a stroke, they're at very high risk of having another stroke if you find they have atrial fibrillation. And in fact, it gives you 2 points. So what you can look at here is, if you look at the overall CHAD score, you can look at the yearly risk of stroke. And patients with a low CHAD score, or 0 to 1, they have a pretty low risk, less than 5% a year. As the CHAD score gets higher, your risk of stroke goes up above 5%. Patients who have a very high CHAD score of 6, they can have a risk of stroke that exceeds 15% a year. So it's a very serious clinical concern, this risk of stroke. The prognosis in atrial fibrillation also is worse than somebody with a normal heart. The risk of stroke is 2 to 7 times higher. The risk of death is 2 times higher. So there's an increased mortality in patients who have atrial fibrillation as well. They're at higher risk of death. Although it's not immediately dangerous, the prognosis is worse if you have this condition. Now, treatment of atrial fibrillation, there are different aspects to treatment. One aspect of treatment is to control symptoms by slowing the heart rate. There are drugs that we can give that slow the connection between the top and the bottom of the heart. They're called atrioventricular nodal blocking agents. They're drugs that affect the connection between the top and the bottom of the heart to slow the signals down. So the signals that are going very fast in the top of the heart, they don't go so fast in the bottom of the heart. And some of those medications you might have heard of are beta blockers, metoprolol or atenolol, calcium channel, another one's verapamil and digoxin. But again, the top of the heart is still going rapidly in this situation, but they're slowing down the bottom of the heart, so the bottom of the heart isn't going so fast. Now, the story of stroke prevention in atrial fibrillation is an anticoagulation story. In 1933, there was an epidemic of bulls in northern Wisconsin, in Minnesota. There were cows dying after eating a lot of sweet clover. And nobody at the time knew why these cows were dying. But there was a scientist at the Wisconsin Alumni Research Foundation. His name is Carl Link. He isolated the anticoagulant factor in this plant that was causing these bulls to die. He called it warfarin. The initial application for warfarin was as a rat killer. And so you can see Carl Link here. He's promoting this agent used to control rats. But what we have found is in controlled doses with close monitoring, warfarin or Coumadin is very effective at preventing stroke and preventing death. In fact, in all of these clinical trials where they studied patients with atrial fibrillation and gave them this blood thinner called warfarin, they found a 64% reduction in stroke and a 26% reduction in death in patients with atrial fibrillation. When you compare it to aspirin, the effects are less significant, but still less. A 38% reduction in stroke and 9% reduction in death with compared to aspirin. In fact, aspirin is not very effective at preventing stroke in atrial fibrillation. The way Coumadin works, it keeps blood from clotting. It works by blocking production of the blood clotting proteins which are made in the liver. Now, depending on an individual's ability to break down the drug, the dosing may vary. It may vary a lot. So somebody may need a dose that's 15 times greater than another patient. You have to monitor the drug closely by measuring this factor called the INR, International Normalized Ratio. Also, the drug is slow acting. You see the effect of Coumadin 3 or 4 days after you take the medication, so you don't see the effect immediately right away. Now, an INR between 2 and 3 is ideal to prevent stroke. You see the risk here. If someone with atrial fibrillation is taking Coumadin, their risk of stroke is much lower when the INR is between 2 and 3. The INR is less than 2, then the risk of ischemic stroke goes up. But if the level of the INR and the level of Coumadin is too high, although you don't have ischemic stroke, you can get intracranial bleeding, or bleeding, which is the main concern, the main complication of taking anticoagulants or blood thinners. So this has to be very closely regulated and varies patient to patient, and it has to be monitored very closely. Now, after many decades, just in the last few years, there have been alternatives to Coumadin. And these alternatives are very, very good. You might have heard of some of these drugs. One of them is called Cardiac, one of them is called Xarelto, and the other one is called Eliquis. Those are the three approved, what we call novel anticoagulants, or new blood thinners that are approved today. And the characteristics of these drugs are they have a very quick effect after taking the medication. Within 2 to 4 or 5 hours of taking a dose, you get the full effect of the anticoagulant, whereas the Coumadin takes several days. So it's a much shorter acting medication. There are fewer drug interactions. There are fewer dietary interactions or food interactions with vitamin K and things like that. So you get a very predictable effect when you take these medications. So predictable, in fact, that you don't need to monitor any levels. There don't need to monitor any INR levels, and you can get a good effect. The prevention of stroke is very similar to that of Coumadin. It's just as effective at preventing stroke. But what makes it better or safer is there's less risk of this very severe complication, which is bleeding in the brain or intracranial hemorrhage. So in all of the clinical studies with these newer drugs, the drugs are safer, there's less risk of bleeding in the brain, and you have the benefit of preventing stroke just as well. Now you can see where these drugs work in the coagulation cascade. Coumadin works on 3 different factors that lead to clotting. And Xarelto, and I forgot to put Eliquis in here, but Eliquis and Xarelto works on this factor called factor 10A. Cardaxa works lower. It's kind of like a direct thrombin inhibitor that works lower in the coagulation cascade. But you can see where these newer drugs work. They work differently than Coumadin does. Now, the way we treat somebody based on their CHAD score, if the CHAD score is 0 or 1, you have a less than 4% year risk of stroke, and the treatment they recommend is aspirin. If your CHAD score is 2 or greater, you're talking about a 4 or greater percent chance of stroke every year, and they recommend full anticoagulation, not aspirin. Aspirin is not sufficient. Either Coumadin would be recommended or one of the novel anticoagulants. Right now, what is approved is Cardaxa, Xarelto, and Eliquis. So that would be recommended if your CHAD score is 2 or greater. If your CHAD score is less than 2, well, I should say if the CHAD score is 1, they say either aspirin or an anticoagulant is recommended. But they give you an option between aspirin or an anticoagulant if the CHAD score is 1. Now, aspirin, clinically, it shows a 25% decrease in the risk of stroke, whereas the anticoagulants, they decrease the risk of stroke by about 70%. So, you know, when you're reducing a risk of 2.8% by 25% versus 70%, it's not a very big difference. But if you have a risk of 8.5% and you're reducing it by 25 or 70%, that's a big difference. So that's why, you know, when the risk of stroke is higher, you want to more strongly consider treatment with an anticoagulant. Now, other treatment strategies. The general treatment strategy, besides controlling the heart rate and preventing stroke, which is the first consideration of treatment of atrial fibrillation, there are 2 different approaches. One is a rate-controlled anticoagulation strategy. That way, in this situation, you're just controlling the heart rate and you're making sure our patient doesn't have a stroke. The other is a rhythm control strategy, and this is a strategy where you actively want to put somebody back into rhythm, because having atrial fibrillation puts you at a high risk of mortality. Atrial fibrillation can cause problems and symptoms. In those patients, you want to keep patients in rhythm. And there are different ways to do this. One is to shock the heart and do a procedure called a cardioversion. Another is to give a medication. It's called an antiarrhythmic drug. This is a drug that's designed to keep the heart in rhythm. And there are also procedures that can try to cure atrial fibrillation. One of them is called pulmonary vein isolation, and the other one is called Mays procedure, which is what the surgeons do. And we'll go into detail into these treatment options. Now, cardioversion is a shock to the heart. This is a perfectly timed electrical shock which is delivered through the chest wall into the heart. Basically, patients come into the hospital, they lie on the table, they're sedated. Paddles are put on the skin, usually on the front and back of the chest. And what you want to do is you want a perfectly timed shock, a high energy, a high voltage shock to reset all the cells to put patients back into rhythm.
Before the procedure, you will be connected to an intravenous line. You will be sedated so you will sleep through the procedure. EKG electrodes will be placed on your chest to monitor your heart's electrical activity. Once you are sedated, special cardioversion pads or paddles will be placed on the skin of your chest or your chest and back. These pads or paddles will deliver electrical shock through your chest to your heart. The shock may be repeated several times until the heart resumes its normal rhythm.
The rest of that. Now, to talk about keeping the heart in rhythm with medications, this is what's called antiarrhythmic drug treatment. These drugs affect ion channels in the heart, and what we're doing is we're trying to keep the heart in rhythm with medication. Some of these medications you might have heard of, or you might have taken. Some of them are called Rhythmol, Amiodarone, Solol, Flecainide, Dofetilide, and Dronedarone. The other name for Dronedarone is Multec. You might have heard some of these guys. The problems with taking antiarrhythmic drugs are some of these drugs can cause other types of rhythm problems. So some of them can be prorhythmic, meaning they can cause other rhythm problems besides the ones you're trying to treat. Some drugs can affect the kidneys, or they cannot be cleared effectively if somebody has kidney problems. And you can't give a lot of these medications in people with kidney problems. Some of these drugs require monitoring in the hospital to make sure that it's safe to take at home. So with some of these medications, we have to watch patients in the hospital for 2 or 3 days before we know they can take it safely at home. Some drugs are not safe when the patients have certain heart problems. When patients have heart disease or coronary disease or heart failure or hypertrophy or a thickened heart, some of these drugs increase the risk of death. So the choice of antiarrhythmic drug therapy is very important and very specific depending on an individual's other heart problems. Now, if you can look over time at treatment and efficacy at keeping patients in rhythm, they look at 3 different groups here. One group of patients that did not take the drug after a cardioversion, and the likelihood that they'll maintain sinus rhythm or stay in normal rhythm. As time goes on, the likelihood becomes less and less that they stay in sinus rhythm. With medications like Sotalol and this other medicine called quinidine, the likelihood they'll stay in normal rhythm is higher. It's significantly higher. But still, over time, you're looking at an efficacy rate of maybe 20 to 40%. I believe amiodarone has the best likelihood of success, and that may be about 50 or 60% over time. But the antiarrhythmic drugs don't always work effectively. In some patients, they work very well, and some other patients, they don't work as well. Now, to talk about catheter ablation to treat atrial fibrillation, this is what we call pulmonary vein isolation. This is a very exciting, it's a newer treatment. We've been doing this procedure here at Silver Cross Hospital since 2008. I think the procedure has become more widespread since 2003. But we're finding that this is a very effective way at keeping patients in normal rhythm. Now, this is a procedure performed by an electrophysiologist. It involves insertions of catheters or narrow flexible tubes through the blood vessels in the groin, through the veins. Kind of like an angiogram, but in an angiogram we go into the arteries. During this procedure we're going into the veins, but it certainly does take longer than an angiogram. We thread catheters until they reach the heart. The goal is to burn or destroy small amounts of tissue in the heart that are responsible for the abnormal rhythm. But the advantage of this is that it's not an open surgery. There's no reason to cut or open the chest. It's very minimally invasive. So the recovery is much easier when you're not cutting. Ablation of atrial fibrillation or pulmonary vein isolation stems from research that shows that most atrial fibrillation signals come from the 4 pulmonary veins that enter the left atrium. This is the upper chamber of the heart. The blood that, the veins that drain blood from the lungs empty into this upper chamber called the left atrium. And most people have 4 pulmonary veins where the blood flows into the atrium, then to the left ventricle, and then out through the aorta to the body. So the triggers for this rhythm problem come from inside these veins. And when we're doing this procedure, we have to get over into this chamber. And when we first do the procedure, we're going in through the vein, and we're ending up on the vein side of the heart. This is the right atrium or the vein side of the heart. That's how we start the procedure. So what we have to do is we get in the vein side of the heart. We have to cross this thin membrane that separates the top 2 chambers of the heart. And that's the technique we have to use to be able to do the procedure. And to get there, what we use is this tiny ultrasound catheter. We put a tiny ultrasound catheter to the right atrium. So with this ultrasound catheter, we can see the right atrium, which is here, and the left atrium, which is over here. And the goal is to get into the left atrium. we have a little curved catheter with a little needle that we can deploy at the tip. And we move that catheter into this thin membrane that separates the top two chambers of the heart. That's called the interatrial septum. And under guidance here, while we're watching under an ultrasound probe and with that, we can poke a little hole through that thin membrane and get access to this chamber. We know that we've reached the left atrium here because when we inject saline or water here, we can see it on the ultrasound. So we know we've accessed the left atrium. Once we get into this chamber, we can put wires through that catheter and then advance the catheter into the left atrium. That's how we get in there. But once we get inside, we use this system. It's called a 3D mapping system. It's a computer mapping system that can tell where we are in the heart in 3 dimensions on the computer. The catheters are movable, and we move around the catheters in this chamber called the left atrium. And we kind of swirl it around here, and we let it go up into the veins and even into the appendage, which is on the front of the heart. We can reconstruct this on a computer in 3 dimensions. We even use a CAT scan of the heart to compare that to, just to make sure that we're in the right place and we're getting all the structure of the heart. And once this is reconstructed, basically we're working real time in that chamber of the heart. We can see exactly where we are at all times in 3 dimensions on the computer. Then what we do is we reconstruct this chamber and we compare it to the CAT scan image. This is the case where you can see the reconstruction we did with the computer and compared with the CAT scan image, and it looks very similar. So it tells us, it can tell us where we are. We have catheters in the heart, and we can tell exactly where we are. Now, what we do is we look at electrical activity in the vein. We have a catheter which is kind of in a curl in the loop here, and there are tiny little electrodes here. We can see the electrical activity in the vein, which is what we're trying to eliminate. And what we do is we make little electrical burns around each vein, 1 point at a time, until all of these signals will suddenly disappear. So there will be no connection. There will be no electrical connection between the veins and the heart. And you can see what we're doing here is we're going step by step around each vein, making tiny electrical burns. You can see on an image here what we're doing on a map when we're going around the veins. And then when those signals disappear, we know we've isolated the veins. And we do this one by one to each vein, the 4 different veins. This is the case we did here at Silver Cross Hospital. Most patients have 4 pulmonary veins. This patient has 3 pulmonary veins. And you can see we went around in a circle here, and we went around in a circle here and here to isolate those veins. Now sometimes to treat this condition, we also have to create other barriers in the heart. Sometimes other barriers in the heart are created. They're called linear ablation regions. And what we're doing is we're keeping signals from going around the heart by creating other barriers to interrupt this abnormal signal. Some of the most common other barriers we create is what's called a roof line. This is a line between the top 2 veins. And when we do this, we make sure that no signals are going across the top of the heart. Another line that's very commonly done is called a mitral isthmus line or a mitral valve line. This is a line from the vein to the valve. And what we do here also is we make sure that no signals are going across this ridge. Sometimes we make other barriers, like between the bottom 2 veins as well. This is an example of where we made other barriers. We isolated the 4 veins here. These are the 4 veins, and this is the appendage. This green structure is the appendage. We isolated the veins. We created a roof line, which you can see here, and then what's called a low posterior line. This is the line between the bottom 2 veins. What we've effectively done in this situation is we've electrically isolated the whole back wall of the heart. A lot of the drivers for these abnormal signals exist in the back wall of the heart, and by eliminating all of the electrical activity here, you can cure atrial fibrillation. Now, what you can see here is these signals in the back of the heart disappear while we're finishing this line. We're finishing this line between the bottom 2 veins, and there's electrical activity in the back of the heart that this catheter is seeing. All of a sudden, that electrical activity is completely gone. That means we've isolated the back wall of the heart. Another way we can look at success of the procedure is by a technique called voltage mapping. Voltage mapping looks at the measured voltage of electrical signals in the heart. And in this example, purple is high voltage. So you can see a lot of voltage in the veins here before we did the procedure. Even in the back of the heart, you can see a lot of voltage. When we finish this case and you isolate the veins and you isolate the posterior wall, what you see here is this gray and this red, which is a lack of voltage. And you can see that electrically the heart is silent, which will hopefully make this procedure successful. So the environment we're doing this in is in the catheterization lab. And you can see we're working here usually with an assistant. We're looking at several different things at once. We're looking at fluoroscopic images or X-ray images of the heart.
What you don't see here is an ultrasound. The ultrasound catheter is right here. We have 3D mapping, which I explained what we use to reconstruct the chamber of the heart to guide us. We have that. We have hemodynamic data. We're monitoring the blood pressure. And we're looking at the electrical signal. So there's a lot of information going on. There's a lot of data there. And there are a lot of people helping us. We have a technician. We have nurses. We have biomedical engineers from the mapping system company who also assist us with the case, who are very, very good technicians and who are very good at doing these cases. So there's a very, very comprehensive team approach, not to mention the anesthesiologist. We're sedating the patients. And everybody works well together. And the team here at Silver Cross is really, really outstanding. And we have a lot of experience doing these cases here. Now, we should talk about other techniques, other ways to cure atrial fibrillation. And there's a technique that surgeons use called maze or mini maze. What they're doing is they're burning and isolating the veins, and they're doing this from the outside of the heart. They're doing this with surgery or minimally invasive surgery. Now, if somebody needs a valve replacement or they need bypass surgery, then they're going to have a heart operation. And while they're doing that heart operation, what they can do is they can go from the outside using these clips, and they can burn the outside of the veins from the outside and isolate the veins that way. This can be done also with minimally invasive surgery, with small incisions in the chest, and using scopes and clamps to burn the veins from the outside. Now, generally, the recovery is harder. I mean, the recovery is longer. It's a more invasive procedure, so it takes longer to recover than from going to going. Most patients that we offer treatment for atrial fibrillation, very few patients will elect for this method initially. Some do, but very few. Most patients prefer going in through the groin rather than having surgery. Now, there was a study that was released in 2010, and that was one of the first prospective studies. The best evidence is when you prospectively follow patients. You randomize them to a treatment group and another treatment group, and you follow them over time, and you look at the effects. And what they did in 2010 is these researchers studied patients who they gave medication to treat atrial fibrillation, an antiarrhythmic drug, and it failed. And one medication didn't work. And they randomized those patients. One group of patients got second medication. The other group of patients got ablation, or pulmonary vein isolation. And you can see how they randomized patients to either get the ablation or to take another drug. And what they saw over time is with patients who got ablation treatment, there was a much higher likelihood that those patients would stay in normal rhythm as compared to patients who got drugs. Now, before that, we would do these procedures, we would see it work on some patients, but as you can see here, it doesn't work in every single patient we do it on. It's hard to know whether you're helping patients by doing this procedure, but this study was a big study because it showed, it gave solid evidence that this procedure was effective in curing atrial fibrillation. Since that time, there have been other studies. A more recent study is called the RAP2 study that was released earlier this year, where they looked at treatment for atrial fibrillation first line with ablation versus antiarrhythmic drug. And if you look at antiarrhythmic drug and ablation, this is the failure rate. So the failure rate is lower with ablation versus antiarrhythmic drug therapy. And this was significant. So what we see is that if we treat patients with ablation, it works better than medication, even if they've never tried medication before. The procedure is more effective, and the goal is to cure atrial fibrillation with this procedure. And this is much more effective than antiarrhythmic medication. So treatment guidelines from 2006, these were old guidelines. Old guidelines, or the way of thinking was, if somebody had recurrent atrial fibrillation and they don't have symptoms, you would thin the blood and control the heart rate. And if patients had terrible or disabling symptoms, you would thin their blood, control their heart rate, try a drug, and try to shock them back to the liver. And if that didn't work, then you would consider ablation therapy. It was what we call a second-line treatment. And also in this other rhythm control strategy guideline, what they do is they classify you based on the kind of heart problems you have and what drug you should try first. You try one drug, and if the drug is not effective, you try a second drug, or you try ablation. Again, this is from 2006. Now, there are new treatment guidelines that came out this year for atrial fibrillation management. Now, because of this evidence, not just this study that I showed you, but there are other studies that show the effectiveness of ablation compared to antiarrhythmic drug therapy. Now, ablation is considered a first-line treatment. So, if you have atrial fibrillation, whether you have structural heart disease or not, it is a very reasonable option to perform catheter ablation as the first option, because this is more effective than antiarrhythmic drug therapy. So So these are new guidelines. And because of these guidelines and this evidence, this is evidence-based medicine, the number of atrial fibrillation ablations has gone up substantially. A lot of hospitals in town across the country are doing this procedure, and a lot of patients are getting cured from atrial fibrillation with this procedure. Now, all procedures have complications. This is an involved procedure, which requires a high amount of technical expertise. And there are complications reported from atrial fibrillation ablation. But overall, given the invasive nature of the procedure, the complication rates are very low. A total complication rate, they will call about 5%. A lot of these complications have to do with bleeding, and it can be very minor. It can be bleeding in the groin or even around the heart. When we do this procedure, we have to thin the blood while we're doing the procedure to make sure that no blood clots are formed while we're working. So by thinning the blood and the development of catheters that have irrigated tip, or they spray water on the catheters to move the blood, the risk of blood clots and strokes from the procedure has gone way down, which is another complication, is having a stroke from the procedure, which is very unlikely. But what you see most often is bleeding, which can usually be controlled. Early on, when this procedure was done, there was a condition called pulmonary vein stenosis, or blockage of the veins when you're burning around the veins. But this is no longer common. In fact, a lot of people in practice have not seen this complication in many years because of the techniques we use to isolate the veins. This is not seen very often anymore. A very well-known feared complication, which is very, very rare, less than 1 in 10,000 or 1 in 12,000 patients, is what's called esophageal atrial fistula. This is a communication between the GI tract and the heart, and the back wall of the heart. The back part of the vein is very close to the esophagus, or where the food goes down into the stomach. And when you're burning in that back wall, the esophagus can get very hot. So everybody is very aware of this complication, and operators use techniques to prevent this complication. They measure temperatures in the esophagus, use very low power, and remove the catheter frequently in the back wall of the heart to prevent this complication from happening. And like I said, it's very rare. Mostly we'll read about this in journals. Of course, I mentioned the risk of stroke. This is minimized with blood thinners and newer catheters. We don't see this very often anymore either. And what can also happen is more organized rhythm problems after the procedure. That's seen sometimes as well. So I hope this was helpful. I wanted to give a general overview and talk about very specific treatment options for atrial fibrillation. I definitely want to spend time answering your questions. Our group is called Heartland. We have 3 electrophysiologists in our practice, and we specialize in heart rhythm problems, and we manage a lot of patients with this condition. So feel free to come and see us if you're not one of our patients. If you want advice or help with management of anything, your heart rhythm problems. Can I answer questions? Yes, sir.
Now, is SVT just another name for it?
Well, SVT usually refers to a very organized rhythm problem that usually occurs in the vein side of the heart. It's a very organized, regular rhythm that has several different causes. And the treatment for that, ablation treatment, is very, very highly effective and very, very safe. But usually when people